have the sugar syrup as well. Easy for you.
I don't know how much to use. Like, at least I know what's in there, but if I go... and then I walk away from here with diabetes, that's not a good thing. Thank you. That's rubbish.
Yes.
Thank you. Thank you very much. I'll just put some cold milk in.
Coffee, sir? I'll ice latte. Ice latte with ice latte, right? Oh, you have it over here.
Enjoy, guys.
Excuse me. Sorry, mate.
When you want to get back to people.
Yeah.
But if you're still waiting on stuff,
Absolutely. Yep.
we thought you'd done a runner.
Yeah.
You just needed another coffee.
I went and made that for you, but you've already got...
Thank you.
Because you enjoyed that one from yesterday I made.
Enjoy it so much. Thank you.
But I'm happy to drink it if you don't.
Thank you. Thank you.
That's the perfect thing. Yeah. It makes them look like a good guy and get a coffee
Yeah.
out of it.
34 years.
Yeah, he's
That's
got
how
it
you
all
do it,
figured out.
yeah.
I said to her that she's now officially off probation.
Yeah, wow.
And so she can hang on to my surname
Yeah.
for another 34 years if she
Might not get to,
plays her
20
cards
years
well.
on Sunday, Rob. That microphone's all yours. Green, just
Remus
when
go.
it's time, put it on. I'm not going to do a big spiel at all this morning, so we'll
Okay.
pretty much roll straight into your presentation and have that.
All right.
Just up there next to the computer. As
Yep.
well. All happy?
The clicker's there.
Yeah.
Clicker's on.
Side. Yeah.
Lovely.
Cool. All good?
Yep. You're going to do a quick intro or no?
No, not really. The way that we'll run it is just pretty much be like Rob
Okay.
down, and then with some, then just kind of just do their own sort of bio.
Alrighty.
Don't worry, it doesn't need to be a.
I'm ready when you are.
You one, but
Yeah.
Take the coffee to sip. Will you drink your water?
There's water in that ice.
You cold.
Good morning, everyone. A big well done for getting out of bed. You tired eyes, but unfresh faces. That's good. Today we're going to have 3 presentations to run through. Just a reminder that if you haven't yet registered, so you haven't got your lanyard or your little conference pack, please make sure you see Molly, Zoe or Lucy at the back there. And I think there's some extra study holders and stickers, so if you have some friends back home that like to drink, I'm sure you do, go to the back table and we'll certainly be able to help you out there. We're going to roll straight to our first presentation. Once again, please feel free to get up at any stage, fill your plates up with food, grab some extra coffees or drinks. That should still all be there with our first break, but after our first break, that might be packed away. So just make sure you eat up whilst you can. But our first presenter, Rob, this is his 3rd conference for us, so we're really excited to have Rob here in Thailand. He was in Thailand last year and then Bali, so he's a fan of the tropical destinations. So let's make him feel nice and welcome as he comes up the stage. Thank you, Rob.
Thank you. How long have I got? How long have I got? How long I need? That's so dangerous. Good morning. You got out of bed. Can you hear me all right? Is this mic on? It's working okay. Fabulous. My name is Rob Timmings and I am the co-owner. I like to say second in charge of ECT for Health, first in charge of my bride of 34 years. It's our anniversary. So she let me bring her to Thailand, which was lovely. and we're really enjoying getting around and meeting everyone. It's really nice to do a presentation on not day one, so I've at least got to make a few connections and see some faces and some names. My background is I'm an emergency nurse by training. I've been working as a nurse for 37 years, and I know I'm ready for a rest. And I currently work for ECT for Health as an educator, and I do a lot of education around Australia and New Zealand, doing this kind of thing, but more small classroom, 15 to 25 people. That's what I do. You can have a look at our logo and Google that. You can probably find me on social media as well. I do the TikTok thing and all the social medias, TikTok, Facebook, Instagram, Tinder. No, that's the one I'm not allowed. Hey, not allowed Tinder. Yeah, all of those. I don't do LinkedIn, so I don't know why. I'm just too busy to do LinkedIn. What I want to talk about this morning, or what I've been asked to speak to this morning, is on sepsis. And whenever I'm pulling together a program or a lecture of sorts, I like to have essentially a point, so that if you heard nothing from what I've said, at least you could go away with the point. And I'm gonna clearly state the point right now, so that if you've fallen asleep for the rest of my presentation, at least you've got the point. Are you ready for the point? Sepsis is not infection. It's never been infection. Oh, it's gone dark. Sepsis will never be infection. Like pneumonia is not a chest infection, it's a consequence of some chest infections. Sepsis is a consequence of some infections, yes? But it's not in and of itself infection. And it's very, very important that we understand that one point before we leave this room today, because some of you are in a position to lead health teams in the management of this thing called sepsis. And the words that get thrown around in that space are, we've got to give antibiotics early. And that would be true if sepsis was an infection. But sepsis is not an infection, which would therefore suggest that perhaps antibiotics as a first-line response are perhaps not always indicated. And I know that I stand before you as a man that's preaching heresy. But I'm hoping that I've got your attention. Sepsis is not infection. So let's go on a little bit of a journey about how we came to this place where there are young and old health professionals in this room that will still hold that belief, that sepsis and infection are so inextricably linked to each other that one cannot divorce sepsis from infection. How did we get here? And I believe it's for the same reason that science always keeps evolving, and our understanding of health management of complex conditions always evolves. I think that it has a whole lot to do with the fact that the more and more we learn, the more questions we have to ask, and the more and more we realise how much we just still don't know. And I think that we can probably translate that to every theatre of practice. So let's have a look at what I want to touch on in this morning's presentation. First things first, we're going to talk about fever. And again, fever is not infection, but we will talk about fever in the context of those that have infection. Whether or not they have fever may be an inconsequential symptom. We're going to talk about the importance of recognising that fever is your friend. Fever's not an enemy. For far too many years, we've taken fever in both children and adults and felt some need, some intrinsic desire to take away the fever as though the fever were a bad thing. And I would suggest that if we can view fever as a symptom of an underlying inflammatory process, that it would be fair and reasonable to say that fever is the smoke, but the real fire is the infection. And if I was to say to a fiery, what should I do when that house is burning down? Wave away the smoke or put out the fire? Where should my focus be? Then I think everybody in the room would suggest that maybe I should focus on putting out the fire and stop worrying about waving away the smoke. For waving away the smoke does nothing for the fire. Would that make simple sense? So we're going to go on a journey to that concept, that fever really is your friend. I'd like to talk about where sepsis comes into this discussion and where septic shock is perhaps delineated from sepsis itself. And we'll have a look at what's trending, because we've got guidelines that are constantly undergoing microevolution since essentially the Sepsis 3 guidelines came out in 2016, because it's 2026 now. Yeah, I can do my math. Alrighty. So first of all, let's define these terms. We have to have a number that we all are going to agree on. And I can tell you right now that if you're a nurse or a doctor in this room that are working in a health service, you probably use some form of a colour-coded ob sheet. Would that be fair to say? Between the flags, a Muse form, acute form, a QADS form if you're in Queensland, where I'm from, some sort of a colour-coded observation sheet. And that colour-coded observation sheet would give certain points to certain parameters that might be outside of that organisation's parameters for wanting you to sit on that patient without reporting. And when it comes down to fever, can I tell you that an elevated temperature, or a hypothermia for that matter, and what an amazing presentation that was yesterday with that ECG from the hypothermic patient. Totally unrelated, that's my ADD. Apples. The colour-coded ob sheet is not, and never has been, an observation chart that tells you what normal parameters are. The colour-coded observation sheet, particularly when we talk about fever, is therefore going to be different from facility to facility to facility. Just in Australia alone, there are 12 different colour-coded ob sheets. Not one of them has been validated. Not one. The colour-coded ob sheet that you're using has not been validated, nor is there a consensus on what those parameters are in your colour-coded ob sheet. It's an insurance document. Sorry. Follow me for more details. They're going to hate me. So, where do we find definitive what is considered to be normal values? Well, we come to conferences and we keep up to date and we look at things like meta-analyses and we look at studies that actually look at what a normal parameter is. And when we come down to this question of at what point does my temperature rise where I now am no longer normothermic, I'm now febrile, or I now have a fever, that number internationally is 38.3. Now that's different to what's on your colour-coded ob sheet. It's different to what's in your clinical guidelines if you're working in pre-hospital medicine. So why is it that some of us think that it's 37.5 or 38 or 38.1? Why is it that we take blood cultures at 38 and not wait until 38.3? Well, the blood culture question has zero to do with normal parameters. Blood cultures are really about insurance. Capturing that 1 in 1,000 patient that might actually have a blood-borne infection. Can you see it has very little to do with the number on a thermometer scale? So 38.3 is what we would consider to be the top end of what is a normal temperature. And it's quite easy to get to 38.3 when you're walking around on these Thai streets. Wouldn't you agree with that? It was a cooker yesterday. Thankful for the pool. So that's fever. So what's hyperthermia then? If normothermia goes up to 38.3, would it be fair and reasonable to say 38.3 and above would also be considered to be hyperthermic? Above normal, hyper, above thermia normal, or temperature. So where fever is 38.3 and above, hypothermia is, well, that's different. That's 38.3 and above. Everyone clear on that? Good. How about pyrexia? Well, pyrexia is an elevated body temperature, and it starts at 38.3. So 38.3, that's your pyrexia. Fever, however, well, that's 38.3. And hypothermia, well, that's different. That's 38.3. Is everyone really clear on that? Because I like to make sure that I'm very clear. Good. Pyrexia is the umbrella term. It's from the Greek, meaning literally to be on fire, pyros. Pyrotechnical display, wasn't that wonderful at the welcome drinks? Pyromaniac, a few of those in the room. Pyrotechnicians. Pyromania. Antipyretic. You can see that word is perpetuated right through our vernacular and even into the pharmacology that we perhaps sometimes use when somebody is febrile. Okay, so pyrexia is an umbrella term, and if we had to break down pyrexia into two streams, we would say that some pyrexias, elevated body temperatures, are intrinsic. They come from within your body. Well, they're called fevers. And the other pyrexias come from externally. They are externally influenced. And before you say, well, isn't a bacterial infection something that's externally influenced? No, because bacteria don't cause an elevated body temperature. More on that in a minute. Let's come back to hyperthermia. Hyperthermia is an extrinsic process. It's I fell asleep in the sauna. I worked out in the hot sun without having a shady hat or a cool place to sit down and a cold drink. It's a baby or a pet that was left in the car seat on a hot day while carer raced into the shops just to grab some milk and bread. And we're going to lose, in Australia alone, another 5 children this summer. On average, about 5 kids will die in a car seat from hypothermias. Hypothermia is also caused exogenously through certain types of medication. We know that from an anaesthetic point of view that some of the neuromuscular blocking drugs, particularly succinylcholine, for the North Americans in the room, you'd call it succinylcholine. The anaesthetic gases, sevoflurane and desflurane and isoflurane, all of those anaesthetic gases can occasionally cause a malignant hypothermic syndrome. In the psych world, I know we've got a few representatives from mental health. In the psych world, some of the older antipsychotic medications, particularly the really powerful dopamine 2 blocking drugs like droperidol and haloperidol and Phenergan, sounds like a discussion of going on that boat on the Drake Passage, doesn't it? But those big antihistamines, those old first and second generation antipsychotics, are associated with a form of malignant hypothermia, which is a neuroleptic malignant syndrome. They're all exogenous. And when that temperature goes up because of those things, falling asleep in a sauna, working in the hot sun, being in a hot car, or having some sort of a medication, none of that is related to an inflammatory process. All of that is related to other biochemical processes or thermic processes that are happening in that patient's body. And it's for that reason that it would be fair and reasonable to say that anyone who is hyperthermic, it would be fair and reasonable to actively cool those people. Are we all on that page? We're going to cool those people down. And we will cool those people down using active cooling, nice cold drinks and air conditioners and ice cold IV fluids, and for whatever reason we're going to get those patients as cool as we can. We will never give them paracetamol or acetaminophen. How do you say that? I was told not to do any political jokes. Acetaminophen, I can pronounce it. or ibuprofen. None of the drugs that we traditionally call antipyretics should ever be given to somebody who is hyperthermic. So I would like you to say to yourself, in fact say to me out loud, I will never give paracetamol to somebody who's hyperthermic. Go on, I want to hear it. I will never be guilty of giving paracetamol or ibuprofen to somebody who's hypothermic. Right? Now, raise your right hand. We're not going to. But I know that there are a few in the room that on the other side of pyrexia, fever, would have limited issue with giving an antipyretic for somebody who's pyrexic. That makes sense, doesn't it? Somebody with a fever. And we'll talk a little bit about that in a moment. So where does hyperpyrexia come in? At what point would we say that your fever or your temperature or your pyrexia or your hypothermia is so high that we can now call it hyperpyrexia? Because pyrexia by itself just simply means an elevated temperature. So at what point is it elevated so much that we can't just say it's elevated, we've now got to say it's really, really elevated. It's hyperpyrexic. And that magic number is slightly different for all people on the planet, but sits somewhere around 39.6. So a trivial elevation in temperature, a low-grade fever or a low-grade pyrexia would be considered to be up to 39.5. Anything above that could be argued that they're now hyperpyrexic. And the reasonable question would be, well, why do we put a differentiation there? Why do we separate those two? Why do these people that are 39.6 worry me more than these people that are 39.5? And fundamentally, it comes down to the fact that if you are hyperpyrexic and the hotter you get, your red blood cells start to dissociate oxygen carriage. Remember that rightward shift of the hemoglobin the dissociation curve, the hemoglobin oxygen dissociation curve. So we have a group of people over here that are sitting in their 40s, temperature-wise I'm talking about, it's not a slur on your age. And I'm less interested in what your temperature is and more interested in what your saturations are. I want to know, have you desaturated secondary to your very, very high temperature? And if you have desaturated, then I am concerned that the temperature may have an impact on your ability to oxygenate tissue. Yes? And it's for that reason that I might preemptively strike with my hyperpyrexic patient and actively seek to try and bring that temperature down. Because I'm not worried about your temperature, I'm worried about your saturation. That becomes my priority, is making sure that you're oxygenating tissue. But over here, if you're sitting in that low-grade fever up to the 39.5 mark, there isn't any evidence to support that a temperature that high, that low, depending on whether your glass is half full, there's no evidence to suggest that's going to have an impact on your ability to saturate. So I'm not that worried about the temperature. Stop stressing about the temperature, because fever is your friend. So there's our normal range. 38.3 is kind of our, and we this isn't new. We've known this for a while. There's a couple of studies that historically I've deliberately chosen some old stuff, but we've gone back to 2002. I think that's far enough back to say that this is not a new revelation. So what is fever then? Where does fever come into play? If I was to ask a group of clinicians, what is the cause of fever? Your answer would be? Yell it out, because YouTube can't hear it. Infection, yeah. And no, infection's not the cause of fever. Inflammation is the cause of fever. Fever is a symptom of inflammation. And you would have to suggest, well, to understand that concept, we've got to understand, well, what is inflammation? Why would I become inflamed in the first place? And when we drill down on what inflammation is, we must understand that inflammation is a normal process and it's part of our healing, is it not? When I damage tissue, I first stop bleeding, I then mount an inflammatory process, I then initiate tissue repair. Isn't that what every wound care course ever taught us? Yes. Stop the bleeding, hemostasis, mount an inflammatory response, start healing. Proliferation, fibroblastic activity, epithelialization, granulation, all of that sort of stuff sits in this space. But none of this can happen while I'm inflamed. And none of the inflammation can happen while I'm still stopping bleeding. So it makes absolute sense that if I'm going to have a tissue injury, I'm going to try and seek repair, yes? And I can't repair unless I first go through this no man's land that we call inflammation. Inflammation, therefore, is necessary for all tissue injury that I receive. And if the tissue injury was caused from an infection, would it make sense that infection happens first, tissue injury then takes place? I have to have an inflammatory process before that tissue can be repaired. Does that make sense? If I have a trauma and tissue injury takes place, a big burn and tissue injury takes place, I must have inflammation before that tissue can be repaired. Yes? If I have an ischemic injury, a myocardial infarction or a cerebrovascular accident, and tissue injury takes place, there must be a phase of inflammation before I can do tissue repair. This is not an infection concept. This is a concept of tissue that has become injured. And make no mistake, when we have an infection, we have injury to tissue. Whether it's a virus that has got into a cell and started to cause that apoptosis, that breakdown of cell material, or whether it has a bacteria that through its alpha toxins and endotoxins have caused direct injury to your tissues, you have tissue injury. And because you have tissue injury, you have to mount an inflammatory response before you can repair that tissue. We're all on board with that. And so if inflammation has a series of symptoms that are attached to it, how do you recognize inflammation as a clinician? Red? Hot, painful, swollen, loss of function, fever. Red, hot, swollen, painful, loss of function, fever are the cardinal symptoms of inflammation. So it should stand to reason that if I've got enough of an inflammatory process going on in my body, I'm going to mount all of the classic symptoms that you would expect of inflammation. And why wouldn't I therefore see fever? And I do. I don't have to have an infection to have fever. Who's a critical care clinician in this room that has seen severe burns in healing? They're febrile. They have fever. They may not have an infection, but they have fever. Who has ever seen or met someone who has seen or met someone that has a child under the age of 3 that is teething? Do they not get high temperatures? Was that an infection that they had in the gums? Or was it trauma causing an inflammatory process that had a thermic response? So fever is a symptom of an underlying inflammatory process. And we have to therefore recognise that inflammation is the cause of fever. Infection is just one cause of tissue injury that mounts an inflammatory response that leads to fever. Does that all make sense right from that point? Because now what we've got to do is we've got to unpack the process. So anytime that I have inflammation, I have a proliferation and a migration of a number of different cells. Often in an infection, very first on the scene are going to be those macrophages. Now think of macrophages as a little bit like outside of a nightclub, you've got the doorman, the bouncers, who also serve a role as cleaners at the end of the night. So they keep the riffraff out, they bounce the riffraff out, but then at the end of the night, when everyone's gone home, they're going to help clean up before they knock off for the night. Macrophages are your clean-up cells. And as they go around and they do their duty and they clean up all of the mess from injury, from infection, Macrophages will sample the antigens from the pathogen that caused the infection and report that to immune central, essentially your white blood cells that we'll call the B cells. And we'll start that whole antibody process. But very, very first on scene, you've got macrophages moving in, cleaning up mess. So I want you to think tonsillitis. It's nasty in there. It's red hot and swollen and the patient's febrile, yes? Difficulty swelling, there's pain there, all the classic symptoms of inflammation. They're well and truly infected and they've got this inflammation going on and there is tissue trauma. And because there's tissue trauma, our immune system's going to be activated. We'll call that inflammation. And macrophages are going to move in and they walk into that tonsils and they're just going to say, my God, what a mess. Let's clean this mess up. And when I clean this mess up, I'm going to need some help. So I'm going to have to call all my macrophage mates. But it's way too cold in this room to do my work. So I need to send a message up to the hypothalamus, the thermostat in the brain, and say, hey, listen, hypothalamus, it's macrophage again. I know you only ever hear from me when you want something. I want something. Listen, we've got a mess down here in the tonsils to clean up. You reckon you can just turn the temperature up for me so me and my mates can get in here and clean up this mess? Hypothalamus receives that message, turns up the thermostat. Temperature starts to rise. And temperature will stay up until such time as the macrophages stop telling the hypothalamus to keep the temperature up. Yes? Now, how that process happens is macrophages talk to the hypothalamus chemically. And when one cell talks to another cell or one tissue talks to another tissue, chemically, we refer to those chemicals just collectively as cytokines. And you've heard of cytokines because in the conversation around sepsis that we're about to start, cytokines are very, very much a big part of a sepsis cascade, are they not? The cytokine storm or the cytokine cascade. So macrophages release these chemicals, these pyrogens. Interleukins are chemicals specifically made by white blood cells, and a macrophage is a type of white blood cell. So interleukins 1, interleukin 6, to a lesser extent interleukin 8, tumour necrosis factor alpha, all of these fancy wank words that you read. Did I say wank? I said wank. That you read when you're reading those difficult to read medical journal articles. All of those are cytokines. And some of those cytokines are pyro, there's that word again meaning fire, pyrogenic, genic meaning to generate, the genesis, the creation. So a pyrogenic chemical is something that is released by macrophages deliberately and specifically to raise temperature. Can you see that this is not an infection that raises your temperature? It's your immune system asking you to raise your temperature through these pyrogenic cascades of cytokines. Now, once those pyrogens arrive up at the hypothalamus then undergoes a process of manufacturing prostaglandins. And prostaglandins are the language that hypothalamus is going to speak, particularly prostaglandin E2. There's lots of different prostaglandins, and they're all kind of numbered and coded. So prostaglandin PGE2 is the key player here, and the hypothalamus is going to make prostaglandin E2, and that will then allow it to raise the thermostat. Take a wild guess that if I gave you a medication that blocked prostaglandin production, like ibuprofen or paracetamol, whether you could mount that thermic response or not. If I blocked your hypothalamus from making prostaglandins, can you see the hypothalamus won't be able to raise temperature? And that's the hook that we lean on when we're giving antipyretic medication to somebody. When I give that hot kid some paracetamol because their temperature's 37 point trivial, just to appease the carer, the parent, what I'm doing is I'm blocking that child's ability to make those prostaglandins, particularly E2, and I'm preventing the hypothalamus from being able to respond to the immune system. Does that, without any preconceived biases, does that sound like that should make a sensible decision that clinically we should stop somebody from mounting an immune response? I'm just going to leave that with you, rhetorically. So hypothalamus raises the temperature. Fever enhances the immune system's response. Fever's your friend. It is rarely harmful. At what point does it get harmful? This side of the room? At around that 39.5, 39.6, we start to be a little bit more worried about that shift of the hemoglobin dissociation curve. Yes? Too good. Now, in the break, you can have a conversation with me, if you like, and attack me violently about febrile convulsions. But I'm also going to give you a little tagline, and this is not something you want to hear, but high temperatures don't cause febrile convulsions. I'm going to leave that one with you because I know there will be questions, and I'm in a panel interview question day in a couple of days, and I'm more than happy to unpack that. Let's get on with whether or not I should be treating fever. So certainly that sustained temperature above that 39.5 could be considered to be harmful. At 39.5, that rightward shift of the hemoglobin dissociation curve starts to happen. Hemoglobin starts to dissociate from oxygen, and my patient may desaturate, and that becomes a concern. Now, every clinician in the room, you've got a patient whose saturations are sitting at 82. Is anyone worried about that number? In your head, does a saturation in a patient on room air at 82, is that number in red? It should be. Good. And what do you want to do when somebody's saturations are sitting at 82? What's your intervention? Put oxygen on. But if your hemoglobin is too hot and it doesn't want to carry oxygen, will oxygen make a difference? It's hardly going to carry if your hemoglobin is hardwired to need a temperature and a pH range. What just happened? Microphone turned on. Have you been listening to me without a microphone for this whole time? Most people can hear me. They may not always listen. Okay, so I don't need to feel that I have to talk so loud now. That's great. Thank you, Mr. Microphone. God's off the microphone. So the interesting thing is that when we have a patient who is desaturated, the first thing we want to do is put oxygen on. And I'm not saying don't put oxygen on, but I am saying give the patient the best opportunity to transport that oxygen, yes? And so in the context of somebody who is profoundly acidotic or profoundly hypothermic, hyperpyrexic, it would be fair and reasonable to actually say, perhaps I need to cool the patient down if I want to give that hemoglobin an opportunity to be able to carry the oxygen. Can you see we've got to work with the fact that we're giving an intervention, we've got to be able to work with that intervention. Giving oxygen is a good thing to do, but we've also got to make the patient receptive to that oxygen. So the old, how many psychologists does it take to change a light bulb model? Only one, but the light bulb's got to want to change, yes? Sure? Okay. We do see seizures and neurological deficits in temperatures right up above that 40.5. So in and of itself, there can be some concerns with very, very high temperatures. Okay. So to treat the fever or not to treat the fever, I think that it would be fair and reasonable to say treat comfort but not worry about the smoke from the fire. So treat the comfort. If my tonsillitis comes with fever and fever only, leave the bloody thing alone. But if my tonsillitis comes with a really sore throat and I'm not eating and drinking and I risk dehydration because of that, do you see, absolutely you would want to treat my comfort. It would be fair and reasonable to say, I'm going to give some paracetamol or some ibuprofen to this person to help to make them comfortable enough with their infection discomfort. But the temperature itself is a different discussion. Comfort measures absolutely would warrant something that was analgesic or anti-inflammatory or antipyretic, even though we know that that's inhibiting the whole process that your immune system's trying to set up. So you're really fighting against what an immune system's doing there. That said, we don't want to leave anyone uncomfortable. And particularly from my theatre of practice, working in rural and remote Australia, when these little kids come in with really rip-snorting infections, they're also dehydrated and in a lot of discomfort. I'm not withholding paracetamol for those guys. I'm giving the paracetamol for those guys because it's about comfort, and that's fair and reasonable. But once they reach that hyperpyrexic territory, then it would be fair and reasonable to say that antipyretics therefore take on a different therapeutic use. Stop treating a number on a thermometer. Okay, so let's talk about what sepsis is, because I opened the conference by saying this morning that sepsis is not what? It's not infection. So what is sepsis? If it's not infection, what is it? Sepsis is life-threatening organ dysfunction. And we can put a full stop there. Now, these are not my words. This comes straight from the Sepsis 3 criteria, the definition of sepsis. Sepsis is life-threatening organ dysfunction. So it's organ failure, yes? That kills people. And make no mistake, this kills people. About a third of people that have sepsis will die from it. Our current statistics in Australia are around about 14% of people with sepsis die from sepsis, irrespective of what we try and do for them. Measured against other countries in the world, like the UK and the United States and Canada, are sitting at around about that 20 to 25% kill rate for sepsis. And I'm going to use those words because sepsis kills, make no mistake. This is a deadly, deadly, deadly syndrome. So sepsis is a life-threatening organ failure. And if we wanted to qualify that, then we can use the full definition from Sepsis 3, and I'll certainly show that in a second. But I really want to send these words home because sepsis is not infection, is it? Sepsis is life-threatening organ failure. And the word infection doesn't even come into the definition here. The full definition of sepsis is life-threatening organ dysfunction. And it's caused by a dysregulated host response. Let's just look at what that bit means. A dysregulated host response is your immune system got it wrong. It got it wrong. It's like a symphony orchestra's conductor that you bought from Temu. It's hardly going to be a beautiful symphony. So when your immune response is functional, with an infection, and I have a tonsillitis, would it be fair and reasonable that my immune response should be in my throat? Yes? Should I have red hot swollen throat? Big tonsils, maybe pus on those tonsils. Those tonsils are purulent, never say pussy. You can't just take pus and put an SY on the end of it. That's a domestic animal. Behave. If I have a wound infection on my leg, a nasty, I don't know, venous ulcer that's infected and not healing, would it be fair and reasonable that it's going to be red and hot and swollen and pussy? I might have some lymphadenopathy and maybe some inflamed groin nodes. It's a localized response, isn't it? If I have a chest infection, is it fair and reasonable that I'm coughing some sort of munyaka from my chest that looks like the nastiest of lung oysters? And I have a temperature and I'm short of breath. That would be fair and reasonable. It's a localized infection, yes? With my bladder infection, with my UTI, that I've got some abdominal pain, and when I pee, it feels like I'm passing razor blades. I've got frequency and I've got difficulty in starting stream, and I don't want to start because I know it's going to hurt. It's dysuric. These are localized symptoms, classic localized symptoms of an inflammatory response to that part of the body where I've got my infection. But with my UTI, I shouldn't expect my kidneys to stop working and reduce my urine production. With my tonsillitis, I shouldn't expect that I'm going to have a drop in my blood pressure or a shortness of breath. I shouldn't expect an altered level of consciousness when I have my wound infection on my leg. Can you see, if my symptoms in my patient with infection don't seem to be localized, they seem to be systemic, please think sepsis. Please think sepsis. Please think that this is something more than just an isolated infection. There is an immune system that has become dysregulated, and other parts of the patient's physiology have been affected by the cytokine storm, the storm that occurs during sepsis. So let's have a look at this full definition in bold white up the top here. This is the definition straight from sepsis, the Sepsis 3 guidelines in 2016. It is a life-threatening organ dysfunction caused by a dysregulated host response, and it's triggered by here is the word you wanted to hear. It's triggered by infection. Is this the definition that you're working with? Good, because this definition is being challenged. The question of whether infection has to be present to actually have a sepsis is now starting to be challenged. And you didn't come here to learn the stuff you already know. You have come here to perhaps challenge your understanding of certain concepts. And let's do that right now. Not before we talk a little bit about our stats. 14% mortality in Australia. Mortality is increased if the patient is in shock. Some statistics will report mortality when the patient enters shock at approximately 80%. That's 1 in 5 of you with sepsis in septic shock. 1 in 5 of you will survive. So what's the trigger? We understand that when somebody has a pathogen, a bacteria or a virus or a parasite or some sort of a pathogenic organism that is going to start infection, that the antigenic signature of that organism are recognised by your immune system. And those antigenic signatures are called PAMPs, P-A-M-P-S. It stands for pathogen-associated molecular patterns. How do you get recognised by your friends? It might be the clothes you wear, your skin colour, your hairstyle. You're recognised by a pattern recognition. And your immune system's no different. It recognises patterns of pathogens. And then it mounts an immune response to that. They're called PAMPs. And when PAMPs are recognised as the trigger point to start or mount an inflammatory process, then all of those inflammatory cytokines get going. And again, those inflammatory cytokines are those interleukins and leukotrienes and prostaglandins, that cocktail of chemicals that are released during sepsis. Hypoperfusion is the hallmark of shock in a patient who becomes septic. But is it just pathogens? Because what we've always understood from the PAMP process is that when somebody mounts an inflammatory response as a result of a pathogen, PAMPs, what continues to fuel that sepsis long after the infection has been dealt with, the sepsis can continue. And what perpetuates that sepsis is not the PAMPs, because they're gone. They've been dealt with. You know, those antibiotics we gave in that first hour, they've been dealt with. What perpetuates that sepsis is now DAMPs, and this is damage-associated molecular patterns. This is the damage itself to the tissues in your body that the infection initially caused. Remember those tonsils that looked nasty, or that piece of lung tissue from the lung infection that looked nasty? That damaged tissue itself releases damage-associated molecular patterns, and that too can fuel the sepsis process and add fuel to the fire, so to speak. And where the literature is now starting to explore is whether or not it was the PAMPs in the first place that triggered the sepsis, like we've always believed, or whether it wasn't really about the pathogen, it was about the damage that the pathogen first caused. You got your infection, damage occurred to tissue, the same thing that mounted your immune response, that inflammatory response. The DAMPs, perhaps they were the primary trigger. And why we think that is because more and more we're finding people that we're treating for sepsis and with sepsis, we don't have a source of infection. We can't find the infection. We can't find evidence of an infective source. It is a true pyrexia of unknown origin. And the damage that was caused was the trigger point. So, quick personal story. My daughter, also a nurse, 23, does a little bit of that volunteer work in sort of third world nations, and last year came home from Cambodia. About 4 days after she arrived home from Cambodia, she got septic, and we couldn't find a source. She was hyperpyrexic. She was very, very unwell. She was so sick, I had to take her to the emergency department that she worked in one of our big Brisbane hospitals. And despite a barrage of testing and the very, very best of care and all of the antibiotics, and I mean all of them, started A and worked to Z with the antibiotic in the pharmacopoeia, she got better and nobody could find the source. She had the barrage of tests. Nobody could find the source. And we're hearing and seeing more and more that there are patients with sepsis that for all the world looked like it had an infective source, but we couldn't find the source of infection. Is it perhaps possible that we're seeing a SIRS-like response, a sepsis-like response in patients that just have injury, not necessarily injury caused by infection? And this is where the literature is now starting to focus on what are the causes of sepsis. Does it always have to be a pathogen? And I think the answer is no, it doesn't. Damage-associated molecular patterns, we've known for a long time fuel the response, but perhaps are they the primary trigger? And if they were the primary trigger, what role does antibiotics play if the trigger for the infection wasn't something that was bacterial? Who's seen sepsis in a viral infection? Right? Did antibiotics help that patient? Okay. Another concept around sepsis that I want to touch on, and that is the concept around warm sepsis versus cold sepsis. You've heard the term, has nothing to do with the body temperature. Somebody in cold sepsis can have an elevated body temperature, and somebody in warm sepsis can be normo or even hypothermic. Warm and cold sepsis is to do with skin indicators. When somebody's in shock, what's the classic skin indicator for shock? Pale, cold and clammy, right? It's a mantra. We teach it to the youngest of our clinicians. Pale, cold and clammy equals shock. Pale, cold and clammy equals shock. That's a conga line that we're going to do on drinks night. Pale, cold and clammy equals shock. Pale, cold and clammy equals shock, right? And it's Mildura that are going to start the conga line. Pale, cold and clammy equals shock. All right. So core temperature is not the factor here. When somebody has the cool extremities, the pale, cold, complex skin indicators, we know that they've moved from a state of warm sepsis, which almost always happens first, into a state of shutdown. And because they're now shutting down, pale, cold and clammy, it's at this point that we can fairly confidently say we think the sepsis has moved into septic shock. When it becomes unresponsive to fluid resuscitation and vasopressors, we're going to call that blood pressure that we have difficulty in rising, we're going to call that septic shock. So sepsis to septic shock, the discussion is around hypotension despite fluids and pressors. Yes? So if you're looking for that, where's the line in the sand between sepsis and septic shock? It's about their BP. So very, very quickly, let's do the 4 R's in 4 minutes. 4 R's in 4 minutes, I'm getting the wind up. The 4 R's, we need to respond. And this is where the question around antibiotics has come into place. Responding early is about treating the sepsis early and treating the infection if there is one present early. Resuscitate, this is where pressors and crystal healing comes into play. Who's into crystal healing? We all love our crystals. If normal saline is not water with crystals, what the hell is it? It's crystal healing, is it not? 20 mils a kilo. And we refer. So we recognise, could this be sepsis? We respond, we resuscitate where necessary, and then we refer. In other words, these patients are not staying with you, they're going to an intensive care unit. Would that be fair and reasonable to assume? If they're sick, they're sick. We recognise sepsis fundamentally with that gut instinct that if this doesn't look like a usual tonsillitis or a usual chest infection or a usual wound infection, there are systemic symptoms on top of the localised symptoms, it would be fair and reasonable to have that inkling that this patient could be septic. But with the SIRS protocols that we've used forever, we refine a few really important features from that. And so you've all heard of the Q-SOFA. It stands for the Quick Sepsis Organ Failure Assessment. Has been refashioned to a Q-SOFA-L, and then there's been some added elements to it. So 2 of the 3 of the following symptoms, hypotension, defined in an adult as a systolic blood pressure of less than 100 despite fluids. An altered level of consciousness, defined as a drop of 2 GCS points. Don't come at me about GCS only being valid for head injury patients. I know that, but we don't have anything better than GCS. And tachypnea. Do not come at me about my pronunciation. Grow up, it's tachypnea. Rapid respiratory rates. You breathe fast for only 2 reasons. You're anxious or you're acidotic. So when somebody has a rapid respiratory rate and we think they could be septic, please think they could be septic and acidotic. It's the only reason we breathe too fast. Respiratory rate is probably the highest indicator for recognising sepsis. When somebody has something that is not a respiratory infection and they have an elevated respiratory rate, please think sepsis. Very, very high yield. Oxygen saturation should be taken. We only put oxygen on patients when their saturations drop below whatever your jurisdiction's threshold is. In most facilities, that has dropped to 92. There's recent reports coming out from the AHA suggesting that maybe we should say that normal sats are everything over 90 in somebody that doesn't have COPD. So perhaps we're not going to start putting oxygen on until people now are down into the 80s. But right now it sits at around about that 92, 93, depending on the protocol that you're using at work. Temperature, we're going to certainly take temperature. Elevated body temperature certainly gives an indicator that there is an affective process going on, and that may be the trigger point. But there are some people that will be septic and became septic and never once got a fever. I wonder if that was damp associated rather than PAMP associated. And an altered level of consciousness with the AVPU now adding C for confusion in between the A and the V. Heart rate and systolic blood pressure. Heart rate elevation and of course the systolic blood pressure drop. So we're doing airway, breathing, circulation and level of consciousness. We're assessing the patient on that Q-SOFA profile. We're looking at other vital signs. Blood sugar level is a highly important one to look at. Blood sugar level in somebody who is septic and entering into shock. In shock, blood sugar levels will rise unless you're a child. Under the age of 5, a child has an inability or a limited ability to be able to store glycogen. They can't mobilise sugar like you and I can when we go into shock. So our blood sugar levels go up, but little kids, their blood sugar level will start to plummet. And because of that, we have to recognise early hypoglycemia, particularly in children who are septic. Inside the first hour, if the patient's in shock, it's still relevant to give antibiotics. Outside of shock, the septic patient, the 3-hour rule is starting to trend. So this whole idea of give antibiotics in the first hour has been challenged simply because we now recognise that not everyone who's septic has a bacterial infection, and giving antibiotics is only important if they're infected with a biotic, something that's alive. We know viruses not to be alive. A patient with a true pyrexia of unknown origin, we have to treat as worst case scenario, and meningitis is currently our worst case scenario. So it would be fair and reasonable to use something that's very broad spectrum that can cross the blood-brain barrier, and that's where ceftriaxone continues to really get a run here. Fairly high doses of up to 2 grams as standard, although some reports are suggesting 4 grams. That's huge. That'll kill everything, even the plaque on your teeth. Vancomycin, or pretty much anything else that ends with mycin, and Pip-Taz, just for shits and giggles, because everyone loves to say Pip-Taz, so we're going to give Pip-Taz whether or not it's the king of drugs or not. We constantly and frequently, let's go back, we constantly and frequently recognise the importance for crystal healing, so fluids. How much fluids? We don't know, but we know the literature is trending us towards the 30 mils per kilo, where the standard was 20 mils per kilo, 10 to 20, moving us more towards the 30 mils per kilo early in vasoplegic shock. Repeating 20 mil per kilo boluses in these patients. In a 24-hour period, it's not uncommon to see in case reports of people having to have up to 200 mils per kilogram in a 24-hour period. Now just pause for a second and let those numbers sink in. If you've got a 70 kilo adult The initial bolus is 1,400 mils. Over 24 hours, it's not unusual that they'll get 14 litres. That's take the plants and water the bejesus out of them, yes? Okay. Correct the blood sugar level, we've mentioned that. Sepsis and shock both raise glucose in adults, but drop glucose like a stone in children. And remember, nobody ever died from high blood sugar. Quickly. But hypoglycemia kills in minutes. Kills in minutes. So we must not tolerate hypoglycemia in anyone, but particularly in children. So what's really new? Antibiotics have moved from the 1 hour mandate to the 3 hours, unless we know that they're in shock. Try and cover those antibiotics then within that first 3 hour window. The earlier the better, we think, but the literature doesn't favour 1 hour over 3 hours. In fact, it doesn't favour 10 minutes over 1 hour. We've got the studies. Paramedics in Victoria actually looked at this a number of years ago and recognised that giving antibiotics before they even loaded and took the patient to the hospital had no more survivability than giving the antibiotics in the emergency department within the 1 hour, within the 3 hours mark. So there is no real good data, good solid consensus that the antibiotics are life-saving. Maybe because sepsis is not infection. I don't know if you've heard that. Sepsis is life-threatening organ failure. Hydrocortisone starting to get more and more of a run. In fact, I don't know any emergency department where in my part of the world that doesn't use hydrocortisone early, and certainly in every patient that is suspected of being in septic shock. So it's a single one-off dose, 200 milligrams of hydrocortisone. And I know you're thinking, well, hang on, isn't this an immunocompromising substance? If I give an immunocompromising substance to somebody who's trying to fight an infection, aren't I essentially signing their death warrant? But no, the infection's not killing anyone. Sepsis is a life-threatening organ failure. And what caused the life-threatening organ failure is a dysregulated immune response. So let's take that dysregulated immune response, that naughty immune system, and say, shut up for a minute. Quieten down that immune system. Turn that immune system off. Give us the reins and we will kill the infection for you. Immune system, you've done enough damage. You can just sit down, park yourself, hydrocortisone the bejesus out of them, and get on with damage control. That's what saves lives with our sepsis patient, yes? Fluids, pressors, organ support. Beautiful. Okay, vitamin C. Have an orange. But mangosteen, my God, how good are those mangosteens? Full of vitamin C. But, you know, for sepsis, your grandmother says, oh, it's good for the immune system, but sepsis is not an infection. There is no good solid data suggesting. It says, don't bother. Normal saline is not the crystal healing of choice. It's something that's a little bit more balanced. Normal saline, certainly in high volume, leads to a hyperchloremic acidosis. We don't want the patient any more acidotic than the lactate that they're already releasing. And remember, our fluids are moving more towards a very liberal use of fluids rather than a conservative use of fluids. I support liberal use of fluids. Don't be political. Some controversial up-and-comings. AI-assisted detection. We're a little bit cautious about this, but punching data into a computer and having the computer come up with whether we think that the patient's septic is an interesting one. Siri and Alexa rate it 5 Google stars. ChatGPT's a little bit moody about it because she wasn't asked first. Phenotype and precision management. So this is actually looking specifically at the type of sepsis that the patient has and using certain biomarkers that are way beyond my scope of comprehension to be able to target manage a septic response for the patient in a similar way that we can take the phenotype of somebody that's got a particular type of cancer and design very specific immunology drugs, immunotherapy medications to target that particular person's type of cancer. So too, perhaps, if we understand that cancer and sepsis are very, very close to each other, they're both damp-associated conditions, then it would be fair and reasonable to assume that there might be a space in this place. More on that another time, maybe at another conference, because this is a really interesting and emerging field being driven by immunologists and oncologists. And of course, the pharmaceutical industry. Recognising that QSOFA and the news criteria are important, responding to the patient in sepsis with antibiotics, access, measuring lactate levels, resuscitating the patient with adequate amounts of fluid, and recognising that pressors very much do have a role, norepinephrine or noradrenaline over aramine. The addition of hydrocortisone, and remember to refer because these people are sick. We're done. Thank you.
Thank you very much. Whoa, sorry. Thank you very much, Rob. And for those who got excited about hearing Rob up here and talk, the good news is back tomorrow for our Q&A, so we'll definitely be able to take questions then. He's doing some diabetes stuff for us on Friday, and there are still a few spots left in his workshops tomorrow and Friday, so definitely get on board with that. So let's hear it one more time. That was awesome. Thanks, mate.
Thank you.
Let's take a quick 5-minute break, stretch the legs, grab a coffee, and we'll get started again soon.
Thank you.